have to say it is an absolutely tremendous honor for me to be here with all of you. How lucky I feel to be together with so many people who are doing so much good work and have wonderful guest speakers to think together with today. So you think about like kind of the work that goes into something and really caring about like equity, right, and maybe changing something, and being able to come together with such a like-minded group of people is really a privilege. So Stephanie London is a member of our stakeholder board for the Cancer and Mental Health Collaborative. The other name for that is the Engage Initiative. They're the same thing. She writes, the stigma of mental illness isolates us from the world and the people around us, even from our doctors. It makes it difficult for people with serious mental illness to get the equal health care we deserve. And so I think that's really what we're going to be talking about today from a couple of different lenses and problem solving around. And I just wanted to introduce our panelists. Come on in, get your name tags if you have them. No worries. So we're joined today by Kate Jamieson, who is a professor of psychiatry at Johns Hopkins, writer on Quiet Mind, one of probably the people nationally who's done the most, I think, to decrease discrimination about mental illness, with her sharing her story and all the advocacy work that she does, in addition to doing a lot of great research and just being a creative thinker. It's wonderful to have you here. Michael Sharp, who is a psychiatrist from Oxford, the president-elect of the Academy of Consult Liaison Psychiatry. One of the things he says that I think is great is that I just wish that psychiatry were regarded as ordinary but useful. And I think just for the last quote of the day for me to share, that Kay says that silence about mental illness bred a quiet ugliness and set in place the conditions for unnecessary suffering and death. And I think that that is something that we all in this room can do something about today. So in that spirit, I'll turn it over to Amy Nirenberg.
Great. Well, I'm delighted to be here and delighted that everybody is here for this gathering. I'm particularly delighted to have both Dr. Kay Jamieson and Michael Sharp. I'm Andy Nirenberg. I hold the Thomas P. Hackett MD Endowed Chair in Psychiatry at MGH, and I'm the director of the Daunton Family Center for Bipolar Treatment Innovation. I've also had the privilege of working with Kelly Irwin in her journey to really help people who have psychiatric disorders plus cancer, and to make sure that not only that they get the care that they deserve, but also to take care of all of the implicit biases that occur when people with cancer try to get their care. Many times when they have psychiatric disorders or illnesses, that's all that the oncologists can see, and they can't see past that. So what we'll do is we'll have a bit of a conversation. I'll ask each of you in turn to give a bit of your story. I'll give you a provocative question to start that, and then we'll have a further conversation after that. So Kay, I think we get to start with you first, if that's okay.
Sure.
If you can pull the mic up so we can hear you. So Kay, what I'd like to ask you to describe, if you're willing to do so, as much as you're willing to share, is to really talk about your experience on both ends of the spectrum of both receiving care for yourself and also being a caregiver for your late husband and his journey with cancer. So if you can talk a little bit about that, that would, I think, be illuminating.
Sure. I certainly have been on the recipient of exceedingly good psychiatric care, first-class doctor that I would go out of my way to say that I'm fortunate in having been able to afford that care, because anyone who deals with advocacy work in this country knows that we have an outrageously bad system, an unfair system. The word stigma, it's a wonderful, it was a wonderful quote up there, but I always had a little bit of a problem with stigma. I go to kind of endless meetings about stigma. And I like the word discrimination. Stigma implies that there's something to be stigmatized. And as soon as you say stigma, it rather conjures up something a little one down. And I think that discrimination has a nice legal quality to it. So it's just a small point, but I think it affects the language. I was fortunate that the psychiatrist that I saw was the opposite of being paternalistic, the opposite of being uninformed. And, you know, I'm often asked, you know, do you think it's better to have a doctor who's empathetic or a doctor who's competent? And, you know, aside from the obvious fact that you like to think that both can exist in the same person, that given the choice of competence versus empathy, I would take competence every day of the week. It is really easy with bipolar illness to get it wrong and to do really bad damage to people. So I would try and get my empathy elsewhere. I mean, as I say, yeah, it's wonderful to try and get it both. To say that you run into problems if you go public about having a severe mental illness, you know, obviously everyone does. And I got everything when I went public. In the book that I wrote, I got huge support from my medical school. Johns Hopkins could not have been more supportive. My department could not have been more supportive. But there are a lot of people out there who really don't like the mentally ill, and none of that have the time to write out why. And, you know, vitriolic letters, hate letters, death threats. I mean, you get a lot of ugliness that you simply were unaware that existed, I mean, out there in the world. But you also come into contact with an extraordinary resilience, just the privilege of going across America in city after city after city, of seeing what people do, how they cope, what they do for their communities, what communities do for them. So you see the gaps and you see, I think, the really good parts. I've been very fortunate to be able to take my illness into writing and teaching and research. And for that, again, I would say I had an extremely supportive husband who was a physician and a psychiatrist, and a person who was a schizophrenia researcher, head of neuropsychiatry at the NIMH. And then he very actively encouraged me to go public. And then not that long after, a few years after I did, he got diagnosed. He had had Hodgkin's disease many years before, 20 years before. Radiation then gave him very severe heart disease, then gave him lymphoma, and then he finally died of lung cancer. And I think that one of the things that you focus upon, and partly because he was a psychiatrist and partly because he lived with my illness as well as I did, is the differences in how society reacts. I mean, people in society are much more empathetic if you've got cancer than if you've got mental illness, and that's just true. I mean, the people, partly because it has affected more people overtly, and people have talked about it more. I think it's also the case that one of the things that I'm always saying to the residents at Hopkins is, you know, we focus in heart disease. My husband, I remarried as a cardiologist, you know, the notion that you might have a heart attack. If once you've had a heart attack, you live in the shadow of having another heart attack. I live in the shadow of I could get a recurrence. I've been fortunate I haven't, but I know the literature well enough to know that that's not given. Is that in psychiatry, we don't put enough emphasis on the terror of recurrence. If you've had a psychotic disorder, that's a real fear. And I just read a book about a poet, Robert Lowell, who was hospitalized 20 times for mania, and he just lived his life in constant fear of that. I think that in both instances, with cancer and with severe mental illness, that there's sort of the ethers sort of tell you that the treatment's going to be a little bit more straightforward than it is, and that the involvement's not going to have to be perhaps as much as it was. And one of the things I was talking about at lunch today was that, you know, in this day and age, after a bone marrow transplant, you do a lot of doctoring and nursing that you may or may not. My husband was a doctor, and he said, I can't figure it out. You know, how are people supposed to figure this stuff out in terms of, you know, home care? I mean, it's not home care. You should be probably in a hospital ward. And so those are all issues, and I think that's true with psychiatric prescriptions as well. You're sort of given medications, and you're sort of given general warnings about side effects and what can happen if you go off them. But there's no way of really saying what it's going to be like to be on these drugs for the rest of your life. So I would say, I have great love for the best side of our healthcare system, which is probably research. I think it's the research. Andy and I were just talking about the amazing things that are going on here at MGH. And that's great, and that's certainly true in cancer. So I think the wonderful, wonderful thing about both these sets of illnesses is the hope that goes along with it. I mean, you can genuinely say to somebody that you can extend hope, and that didn't used to be the case. Thank you.
Oh, thanks so much. I'll certainly ask some follow-up questions in a bit. Dr. Sharp, I'm really interested in your career in looking about a co-occurring medical illness and psychiatric illness. What is it that you've seen that really has worked well and perhaps not optimally, both clinically and in research?
So let me do a little bit of a personal journey, because I think for things to work well, sometimes there is magic, perhaps. Maybe there's magic here, but mostly it comes down to having a real passion to get something done. It comes down to being able to work with, engage other people to do the same thing. And then it just comes down to determination. So let me just say a few things under each of those things, if I may. When I was 16, I was at school, and my grandfather, my father's father, who was many ways my kind of idol in life, he had retired, his wife had died, and he lived with us, and he got bowel cancer. I was just a 16-year-old kid at school. But it so happened that my mother and my father were both out of the house. When I came home from school, I found myself not only spending time with him, but as he got frailer, actually doing some physical care of him. And he was a very proud man. And I remember having to, as a 16-year-old, lift him out of bed onto the commode. So that was probably a formative influence from, we never know what forms these things, but I'm aware of the fact that's affected me emotionally. That was a formative influence. And I went on, I went and studied psychology. I worked for a year in the States, and I went to do medicine, and I started doing internal medicine. I did quite a lot of internal medicine. And part of the rotation was on the cancer wards. And I guess because of my background in psychology, I really initially got a real buzz out of doing the practical medical stuff and being competent in that and helping people. But I really felt the person was too often missing. The medicine was very technical. The person was missing. And again, I can remember a case, a woman in probably about 40 with breast cancer. And I was just the junior physician on the ward. And of course, she was, all stoical for the senior people. But when it was just me there, she was able to express her distress and to cry. And I didn't know what to do with this stuff. I was a junior doctor. So I kind of tried to listen. It seemed to be a bit helpful. But to be honest, no one else was very much interested in that. So perhaps not surprisingly, now you know my story, I went on from internal medicine to train in psychiatry. And all from the beginning, I've had this passion to try and put the psychological, the person into medical care. So that's, and as Kelly said, I'm continually struggling against this view that psychiatry, which of course was started with the separate asylums in the mid-1800s, has been, we've split our medicine into mental medicine and physical medicine. And we just go about every day as if that's normal. It's weird. And it gets more weird as you realize that these things come together. There are people who just have psychiatric illnesses. There are people who have uncomplicated medical illnesses. But once you get into either older people or more severe illnesses, it is the norm to have a combination of what we call mental and what we call physical illnesses. So that's been really my mission to do something about that. So I got involved in CL psychiatry. So moving on now to collaboration, I want to mention a wonderful physician who actually died of lymphoma just a few years ago, a guy called Wayne Caitlyn. I don't know whether you knew Wayne Caitlyn.
Yeah.
Wayne Caitlyn is a psychiatrist. He grew up in New York. He was working in Seattle. And I met him through this organization. I now have the honor to be president-elect of the Academy of CL Psychiatry. It used to be called the Academy of Psychosomatic Medicine. And Wayne developed a model called collaborative care. And he was passionate to improve the psychological and psychiatric care of patients in primary care. And he tried educating the doctors, didn't do very much, tried giving them guidelines, didn't do very much. So he decided the only way to do was get beside them and work with them. But it was very difficult to work with all the patients in primary care. You couldn't spread a psychiatrist that thin. So he developed a model where he had care managers who could have been nurses or social workers who then formed a team. So you had the team of the psychiatrist, the primary care doctor, and a lot of the patient contact done by these care managers, be they social workers, nurses, or whatever. And there are now, I think, over 100 randomized trials in different settings that find that collaborative care really does improve the quality of care. So when I was working in Edinburgh at the time, this would be about 1999, and I thought, well, we could adapt that for cancer care. And I was fortunate to get a research grant from a big cancer charity in the UK called Cancer Research UK. And we developed and evaluated in a very iterative way. And I think, I agree, I think what you're doing, Kelly, having read your stuff, there is no simple solution to this. Co-location is not the answer. Educating oncologists is not the answer. Empowering patients is not the answer. It's a whole pile of stuff. You have to create a whole package of ways of tackling this really very difficult. We shouldn't underestimate this problem. It's a really very difficult problem. And so we iteratively developed a package, and we've now done 3 randomized trials of it. Now, this was specifically, because research, you have to be specific, this was for people with depression. We didn't include people with bipolar or people with schizophrenia. It was focused on major depression. And all we did was systematically apply depression care to people as part of their cancer care. And we got embarrassingly large effects. So we did 3 trials. We did called Smart Oncology trials, all published in Lancet journals. And the last one, Smart Oncology 2, we had a difference in the improvement of depression, 50% drop at 6 months, of 45% absolute difference. I mean, this was almost too embarrassing to publish. And really the shocking thing, though, is it's not shocking that doing good depression care improves depression. What is shocking is what the usual care arm had. At 6 months in usual care, 17% of people had a 50% drop in their depression. So there was the data monitoring committee even wanted to stop the trial at one point because they said one of your treatments is seriously futile, and that was usual care. Okay, so you have to do things together. Atul Gawande, a local surgeon, a wonderful writer, talks about medicine previously being done by cowboys and now needs to be done by pit crews. You know what I mean by pit crews? They work around those racing cars. They can change the tires in how long? 2 seconds. 2 seconds. And that's because everyone has a very specific job, but they have rehearsed so well that they work fantastically as a team. So one guy's job will be the left-hand front wheel. You know, that's his job. So all he could do on his own is the left-hand front wheel, but the team together can do a car. So teams, what Wayne told us was doing stuff together in teams. So the final bit is determination. You only have the determination if you've got the passion, I guess. I think doing clinical trials is really hard. Implementing trials in practice is probably harder. And I think the only answer to it, to be honest, is to be as charming as you can, be as motivational you can, and just bloody keep going. Don't be beaten. You've just got to keep going. And I think that the thing the lesson I'd take away from this is my, optimistic naivety, is that it would be quite an easy problem to solve this. It's such an obvious problem that mental health care and physical health care, cancer care, can be brought together or bridged or integrated. So obvious. We could just do it. And I think, to be honest, in my experience, most physicians and oncologists do want to do it, in theory. The practice is so hard. The barriers, the funding barriers, the physical barriers, the amount of time there are for the consultations, the knowledge barriers, some attitude barriers. It's a really hard problem. But what's worked for me is keeping going.
Thank you so much. You both eloquently described what it's like both to do the research and your passion for it, and being able to find some optimal level of the way you want to be treated, of the way that you want to be able to have others treat other people. How do you see the path forward for really being able to make the types of treatments really person-centered? Right? Because a lot of our systems here in the United States are institutionally centered. They're really not built around the everyday needs of people in many places. Again, Kate, it sounds like you've been able to get the care for yourself and for your former husband in ways that were really satisfying. But what ways do you think it could have been better as you look back?
Well, I say only partially facetiously, the outcome could have been different. I mean, in the sense with cancer, both cancer and bipolar illness and schizophrenia and some depression, death is in there, and I think that it needs to be addressed more fully. And whether it's a patient who's nearly died from a suicide attempt or when it's inevitable that somebody with cancer is going to die. And I think that has to be much more a part of the discussion than it is. Again, easier said than done. I think the severe mental illnesses probably bring up a whole different set of problems than depression. I think it's great that depression is being done, but with severe bipolar illness and schizophrenia, you just run into a whole set of additional problems. The complications of the medications, the complications of the attitudes and behaviors and so forth. One of the things that I think that probably, because the age of onset of the major psychiatric illness is so many decades earlier on average than medical illness, not that it isn't medical illness, but other medical illnesses, we tend not to use advanced directives enough in psychiatry. And I think it's one of those things that you could perhaps, having done it with a psychiatric patient earlier in life, then when they are older, if they become so impaired that they don't have the judgment to agree to the kinds of treatment that are involved in cancer, which is not uncommonly the case, then you at least have something in writing or something to talk about. So, I mean, one of the things that I routinely emphasize in teaching in public advocacy is, I have, like many patients, an advanced directive that were developed when I was compos mentis, or as compos mentis as I get. I mean, and so that I could say, you know, if I get manic again or if I get suicidal, I want to be hospitalized against my will. I want to be taken to Johns Hopkins. I want to be treated there by the following doctors. I want to be on the following floor. I want to be, you know, I want ECT. And because that gives moral authority to families. And I think these issues come up in cancer in a very different sort of way. And if you get good cancer care, it's great. But I think even in the case where we were getting very good care, for sure, people just didn't even ask us any of these questions. I mean, I was quite amazed. And I don't know if the assumption was, well, of course, they sort of know or whatever. But I think when you've got psychiatric illness that compounds the problem of judgment and sometimes compounds the problem of fear, then you want to work these things out when people are better and well, rather than reaching the crisis point down the pike. And I think that's just terribly important. And just being straightforward and you know, just calling, you know, saying this is, you know, in the case of severe mental illness, you know, you're going to die by suicide, very likely, if the following doesn't happen, that this is a real risk. And we're so walk around those issues. But death is in the room, and I think that that's something that really needs to be much more fully discussed.
You know, it reminds me of a remarkable obscure book called The Practice of Autonomy by Carl Schneider from Wisconsin, where really what Carl Schneider does in a very elegant way describes the entire philosophy and history of the doctor-patient relationship. And he says that any clinical encounter will be on a spectrum from physician or clinician authority to patient autonomy, and that you have to get to the right level for every encounter. And I wonder in your work with trying to get people to, let's see, be less paternalistic in many ways, how do you try to change the culture so there's more of a shared decision-making and perhaps negotiation around these issues of autonomy and versus physician authority?
What are you asking that to? Me?
Yes.
I think if to go to roll that into your question, which I think was something about how we're going to get to patient-centered care, I think there's two ways. One is knowing where we want to be and having a clear vision for that. And then the second thing is the journey to that, which isn't going to be straight to the vision. So I think, are there any oncologists here? I think that, you know, it's very easy. It's very easy to say that oncologists should just be better. They should just know about psychiatry. They should spend longer with the patients. They should provide everything. And, you know, that's not going to happen. You might risk then ending up with an empathic doctor who is not, not a competent oncologist. You know, oncology is hard. Oncology is moving really fast. They're under, I don't know about how it is here, but they're under huge pressure to see large numbers of patients. It is not realistic to say to the oncologist, just take a few hours out, you know, it's not going to happen. And so I think the answer, and the other thing we need to bear in mind, and again, I think it's changing, but medical education for the non-psychiatrist is still very technical. It's very much about what the doctor's going to do. And again, I don't think that's just how it is. There's no point kind of blaming them for that. That's how it is. So I would go back to what I said before, is that where I think we want to get to is building a team around the patient, not forcing the patient to divide themselves or contort themselves to fit around the teams. But that's quite a big ask, because that's not the way we do things.
Well, you're almost asking to change training so that can happen.
Well, to change training, and well, the trouble is you just change training and don't change the day-to-day structures. People forget their training very quickly. Yeah. So you have to actually change the structures. So, you know, I would advocate in this setting that there ought to be now again, there aren't going to be enough Kellys and people, but what we are trying to do in my hospital is build teams that have a psychiatrist and or psychologist on the medical team. And then there is an effect of not only having a wider expertise in the team, like the pit crew, but there is one can educate and show people have an authoritarian style, a more collaborative style. Because I think it's a collaborative style we want. And so there's corrective things one can do. The great thing about psychiatry, at least until recently, it didn't know very much. This is a tremendous strength, because we were forced to listen to patients. And, a lot of, if you go back, if you read about some of the great people from this hospital, actually, writing in the 1890s, early 1900s, that's all they could do, really. They listened to the patients, and they gave psychotherapy sometimes. It wasn't called that, sometimes it was called, it was using the physician's authority, but it was about caring for the patients. And then the tremendous strides in technology has squeezed that stuff out and made it seem less important. Up to now, that hasn't happened in psychiatry. So we're stuck with, guess what? Actually listening to the patients and forming a collaborative relationship. And so in a way, I see psychiatry as being a custodian of that aspect of care, which has kind of got pushed out by technology. And I think one of the things we can do is to put that back.
So in that paradigm, how do you think that you can also foster more shared decision-making? Either one of them.
That's a K question.
Well, I think I think for starters, you can ask people, we're going to be in this together. What is it that you think you would like? What kind of style? People vary in how much they want to be told about and how much they want to be told what to do. How much do you want to know about your illness? What can we provide for you? So a lot of this can be done in video form. Obviously, in psychiatry, you can do a lot of educating by just making things available to people with different kind of styles of listening and communicating. And I think that that's an important sort of thing. It's just ask. I'm staggered by how often people go into a room in a psychiatric ward and don't ask people, what is it that you want? Or after someone's attempted suicide or been manic and hospitalized, what is it that I did that was helpful? What is it that I did that was really not helpful, that really made you feel worse or upset or agitated? What can your family do that might be helpful? What do you think you can do? But have these kinds of discussions when people are feeling okay, but get them involved in what it is that they have found helpful. So a lot of people with severe depression want somebody in the house so that they're safe, but they want them at the periphery so they don't get into arguments or paranoid diatribes or over neediness or things that are going to alienate the person they want to keep in. But people don't talk about those things. Some people just want to be drowned in DVDs. Some people want to be, just left alone. I mean, people are very, very, very different on that. And I think they need to be asked.
Part of what you provoked me to think about is that in our training, we are almost never taught any formal negotiation skills. And yet you're really, that's at the heart of what you're talking about in many ways, of how do you negotiate with your colleagues to get the best care? How do you negotiate with people who are seeking care, with their family members, to try to integrate that? How can we move forward with that?
So another of my things, one is to make psychiatry ordinary but useful. The other thing is I think we need a science of the art of medicine. And another of these splits that we have science medicine, which is looking at scans and giving doses of drugs. Then we have relating to the patient, which is thought as the art of medicine. And it's split off. But why can't the art of medicine be as rigorously evaluated as the science of medicine? There's no reason, we were just talking the way down here, there's no reason why you can't do a clinical trial of a different way of a relationship with the patient, a different way of explaining things. So if science has the upper hand as the determining thing, we shouldn't abandon a major part of patient care, sometimes the only useful part of patient care, to something called art. It should be encompassed within the science, bearing in mind, we're using a broad meaning of science. So that's what I think we need to legitimize these, not as frills, but as part of the core scientific medicine business.
So Catherine Montgomery, in a book called How Doctors Think, which is not the book by Groupman, talks about medicine as being neither an art nor a science.
Okay.
But talks about medicine as being the practice of phronesis, which is the Aristotelian notion of practical wisdom, which I think really contains everything that you've talked about how do you get to a point of practical wisdom, not only in terms of the knowledge and the skill that you would expect someone to have, but also in interacting in ways that are ultimately, will decrease suffering rather than increase suffering, as the Buddhists would say.
Yeah.
Well, we're almost out of time. Any last words for this part?
I would just, if I may, just say thank you for the questions, but thank you very much for inviting me and for having someone from the UK to share this. And can I also say how impressed I am and how slightly guilty I feel that in our research we took the easy course of just doing major depression, and I feel so much the need for that to be taken further to include I would say more severe, but these often more complicated in terms of cancer care illnesses, and to congratulate Kelly on pushing this forward. If any of you thinks doing this kind of thing is easy, Kelly doesn't show it, but I'm sure, and she's never said to me it's hard, but I'm sure it is. So I'd like to thank you very much for the opportunity.
Well, I would like to say, I think what you've done with major depression is fantastic, and it sets a standard. I don't think you can start off with lower population illnesses that are more difficult to manage and go anywhere. I think what you've done is fantastic. It's just that as someone with bipolar illness and a family full of it and a clinic full of it, these are people who do get routinely left out. But I think it's an obvious next step, but I don't think you can take that step without what you've already done, which is extraordinary.
Thank you.
Okay, Michael, thank you so much for sharing your time with us.